Hello, my name is Dr. Omide, and I'm going to continue with the lecture series on the back, yeah, gross anatomy of the back. So we are going to discuss the movements of the vertebral column. So the range of movements usually vary depending on the region, like cervical and lumbar have very wide range of motion, where also it can depend on the individual, like acrobats are very flexible, yeah. So aging reduces the range of motion of the vertebral column. We have different movements: flexion, extension, lateral extension, and so on and so forth. So lateral flexion is when you bend to the right or to the left from a neutral position, while lateral extension is returning to the erect position from lateral flexion. So what limits range of movement of the vertebral column? Number one, the thickness, elasticity, and compressibility of the intervertebral disc. Then you also have the shape and orientation of the zygapophyseal joints, where cervical and lumbar, they are close to horizontal, so the range of motion is high. Then there's the tension of the joint capsule of the zygapophyseal joints. There's back muscles. The resistance of back muscles and ligaments can limit movement. Attachment to the rib cage can reduce movement. Then we also have the bulk of the surrounding tissue. In the cervical region, we have less bulk, so there's high range of movement compared to thoracic region, for example. So these are the factors that limit range of movement of the vertebral column. So the movement of the vertebral column is caused by back muscles. There is the effect of gravity, and action of anterolateral abdominal muscles also affect the movement of the vertebral column. So remember, the site of movement between adjacent vertebrae is mainly at the resilient nuclear pulposas of the IV disc, and that serves as the axis of movement. And we also have the zygapophyseal joints that permit some movements and restrict others. So movement occurs at the nucleus pulposa and at the zygapophyseal joints. Movement never occurs at a single segment of the column except at C1, C2. Yeah. Small movements can occur in the thoracic region, but the vertebral column actually moves because of summation of all the small movements produced. So we have free movement in the cervical and lumbar region. Why? The IV discs in this region are thicker relative to the size of the vertebral body. Number two, the zygapophyseal joints surfaces. The articular surfaces are large and almost horizontal, and the joint capsule in these regions are loose. The neck is relatively slender with less soft tissue bulk, therefore the range of motion is high. So those are the four, if you ask the reasons why there is high free movement in cervical and lumbar region: thick IV discs, horizontal zygapophyseal joint surfaces, loose joint capsule in the ZP joints, and the neck has less soft tissue bulk. This image extension and flexion of the column, right bending and left bending, and the rotation. So flexion of the vertebral column is greatest at the cervical region, and extension is most marked at the lumbar region, while lateral flexion of the vertebral column is mainly at the cervical and the lumbar region. Remember, the thoracic region has to be stable because it's protecting vital organs, the heart and the lungs. So the stability factors in the thoracic region: number one, the IV discs are thin relative to the vertebral bodies. Number two, there's a connection to the sternum and the ribs. Number three, the joint planes are actually lie on an arc centered on the vertebral body, so they only permit rotation and they have limited flexion and extension. So in cases of a crash or compression fracture of the vertebral body, this can occur if you have forceful flexion. So you can get compression fractures. So severe hyperextension can also injure the posterior part of the vertebra. Hyperextension injures posterior part of the vertebra and tears anterior longitudinal ligament. And hyperflexion injuries cause locking of the cervical vertebra. Okay, so this just shows you compression fracture. If there is force from both sides, you compress the anterior part of the vertebral body. We have what you call whiplash injury. So in hyperextension, that's how the injury will occur, and hyperflexion, you tend to. So hyperextension, you tear the anterior longitudinal ligament. Hyperflexion, you can get compression fractures because vertebral anterior parts will be affected. So in flexion, you tear the posterior ligaments, like the supraspinous ligaments. And in hyperextension, you're going to tear the anterior longitudinal ligament. Remember, it runs on the anterior surface of the vertebral body. Interspinous ligaments on the posterior between the spinous processes. So hyperextension of the head, especially when there's force that will cause hyperextension, it leads to hangman's fracture, which we said fracture the pars interarticularis, leading to cervical spondylolysis. Hyperextension also causes rupture of anterior longitudinal ligament, and spinal cord can be affected. So this is what happens in spondylolysis of L5. So when you have fracture of interarticular parts of L5, okay, so this is L5, and then when you have fracture at the interarticular part of L5, what happens? This vertebra will shift anteriorly with respect to the lower one, and that's what we call spondylolisthesis. So spondylolisthesis is forward displacement of L5. It moves anteriorly relative to the sacrum, and therefore you're going to impinge the chorda equina that is passing in the vertebral canal. So you compress it, leading to low back pain and lower limb pain. It's also called failure of centrum of L5 to unite. So that's embryonically. Then we go to the curvatures of the vertebral column. We have 4 curvatures: cervical, thoracic, lumbar, and sacral. So the thoracic and sacral, they have something in common. They are concave anteriorly, and they are the primary curvatures. What do we mean by primary curvatures? They develop in the fetal region based on the flexed position of the fetus. We retain these curvatures throughout life as a consequence of differences in height between the anterior and posterior part of the vertebra. So the sacral curvature differs in males and females. So in females, the curvature is reduced and the coccyx protrudes less. But in male, they have a greater curvature of the sacrum and the coccyx protrudes more. Remember, in the females, you need it to aid in birth or delivery. The fetus is supposed to fit and allow exit, okay? So you don't need it to be curved or with a protruding coccyx. Cervical and lumbar region, they have a lordosis, yeah? This thoracic and sacral region, this is what we call a kyphosis, where you are concave anteriorly, and we say these are the primary curvatures that develop in the fetal time period, and you retain them. While cervical and lumbar curvatures are called lordosis, so they are concave posteriorly. So they are concave posteriorly, concave on the posterior aspect, and the secondary curvatures. Why do we say they're secondary? They result from extension from flexed fetal position. So during fetal period, they appear, but they do not become obvious until infancy. Okay, so they are maintained primarily by the differences in the thickness between anterior and posterior parts of IV discs. Remember, thoracic and sacral curvatures were maintained by the differences between the height of anterior and posterior parts of the vertebra, while cervical and lumbar curvatures maintained by the difference between anterior and posterior parts of the IV disc. So cervical curvature are actually evident when the child learns how to raise the head while prone and hold the head in an erect position, while lumbar curvatures actually become apparent when an infant assumes an upright posture, standing, walking. And this lumbar curvature is more pronounced in female, and it ends at lumbosacral angle when it's formed between the junction of L5 and the sacrum. So these curvatures, they give the vertebral column flexibility, so resilience to allow shock absorption. And this flexibility of IV discs is passive, while the flexibility of the curvatures is active. Why? The flexibility of IV disc is limited by the zygapophyseal joint and longitudinal ligament, while the flexibility of the curvatures is usually dynamic. It's active and dynamic, so it's resisted by contraction of antagonistic muscle. So the long back extensors resist increased thoracic kyphosis, while abdominal flexors help to resist increased lumbar lordosis. That's why we say the flexibility of the curvatures are actively resisted by contraction of antagonistic muscle, while the flexibility of IV discs is passive and they're limited by zygapophyseal joints and the longitudinal ligaments. So when you carry additional weights, like if you have large breasts or pendulous abdomen or a pregnant woman, Chris, when you sit in remain seated for a very long period of time, there's less, especially with two, you tend to be slumping and sitting up straight all the time. You sort of change your cycles between back flexion and extension. That way you do to minimize stiffness and fatigue. So when you alter between active support of back extensors and passive resistance provided by the ligaments. So we have abnormal curvatures, for example, abnormal thoracic kyphosis. This is what we call a hunchback or the Dowager's hump in older women who have osteoporosis. Okay, so when you have osteoporosis or compression fractures, you get fractures of the thoracic vertebra or collapse leading to kyphosis. So kyphosis gives you an increased anteroposterior diameter. Look at this anteroposterior diameter on a spine and on a hunchback. You increase anteroposterior diameter of the thoracic curvature. So this is hunchback or thoracic kyphosis. Then we have lumbar lordosis, okay, especially in pregnant women or people with pendulous abdomen. So what happens when there's anterior rotation of the pelvis at the hip joint, increasing the lumbar curvature, okay? So there's associated weakening of trunk muscle. So when there's obesity or in pregnancy, the line of gravity changes, therefore you develop a temporary lumbar lordosis. This is a normal spine. Look at this lumbar lordosis. Compare with this one that is exaggerated, okay? Scoliosis is when the back is crooked or curved laterally, okay? So it's usually accompanied by rotation of the vertebra and the spinous processes turn towards that lateral curvature. Mostly we see it in pubertal girls and the different stages or location of the scoliosis. You can have a thoracic scoliosis, a lumbar scoliosis. You can have both combined thoracic and lumbar scoliosis. So what causes scoliosis? It could be a hemivertebra, half of the vertebra did not develop, or your muscles are weak, or they have asymmetry, or differences in the length of the lower limb, herniation of the discs, or standing, improper position, improper posture. So all these things cause scoliosis. So you can have kyphoscoliosis when you have excess thoracic kyphosis combined with scoliosis, and that gives you an abnormal anteroposterior diameter of the thorax, and that affects the expansion of the lungs. So blood supply to the vertebral column, you have vertebral and ascending cervical arteries in the neck, posterior intercostal arteries in the trunk, subcostal and lumbar arteries in the abdomen, and iliolumbar and lateral and mediosacral arteries in the pelvis. Remember, this provides a nutrient artery that enters the vertebral body to supply the marrow space. So basically, all these arteries, you have segmental supply of the vertebral column. These arteries provide periosteal and equatorial branches, basically. So this just shows you the segmental supply of the vertebral column. So deep cervical, ascending cervical in the neck, the intercostals in the thoracic region, iliac artery, the sacral and lumbar arteries in the inferior portion. You can see the lumbosacral arteries there, and so on and so forth. Spinal veins will follow the spinal arteries, then they drain in the internal vertebral plexus and external vertebral plexuses. So this just shows you the internal vertebral plexus here and the external vertebral plexus. So the vertebral bodies will drain into internal vertebral plexus, which later drain into the external vertebral plexuses. Then, of note, we have the basivertebral veins, which are large and tortuous veins of the vertebral bodies. We have intervertebral veins. These receive blood from the spinal cord in the vertebral venous plexuses. So they accompany the spinal nerve through the interforamina and they drain into vertebral veins of the neck and segmental veins. Vertebral veins will drain into intercostal, lumbar, sacral veins, all those segmental veins. The vertebral column is innervated by meningeal branches of the spinal nerves and its rami. So you have nerve fibers to the periosteum, to the annulus fibrosus, to the ligaments for pain and proprioception. and sympathetic fibers come in to innervate the blood vessels that stimulate vasoconstriction. Some nerves also go to the dura. So the vertebral column, every aspect is innervated. The zygapophyseal joint will get innervation from posterior rami. Meningeal branches of the spinal nerves will also be given to the vertebral column to innervate the periosteum, annular fibrosus, the ligaments. So you have pain fibers, proprioception fibers, sympathetic fibers for vasoconstriction, and nerves that will go to innervate the dura. So back pain is caused by any pathology on any component of structures of the back. The fibroskeletal structures, meninges, joints, muscles, the nerves, when you compress them, all these lead to pain. Okay. Next lecture we'll discuss the muscles of the back.